Today, we are going to be giving you a detailed breakdown of the measles virus and pneumocystis pneumonia.
Measles is a viral infection caused by the measles virus, which belongs to the family Paramyxoviridae, genus Morbillivirus. The measles virion is spherical, enveloped, and contains a single-stranded, negative-sense RNA genome. It possesses surface glycoproteins, hemagglutinin, and fusion. Measles spreads through respiratory droplets, which makes it an airborne pathogen. The virus can remain airborne or live on surfaces for up to 2 hours, which makes cleaning surfaces very important. Pneumocystis pneumonia is a fungal infection caused by Pneumocystis jirovecii, a yeast-like fungus. P. jirovecii exists in two main forms: tropic form, which means feeding, and cyst form. The tropic form contains thin walls, around 1 to 4 nanometers, while the cyst form has thicker walls, around 5 to 8 nanometers. Its cell walls lack ergosterol. This makes common antifungal agents ineffective. Transmission of P. jirovecii occurs primarily through the airborne spread of cysts from person to person with no known environmental reservoir. This means that P. jirovecii is not found living naturally anywhere other than in humans.
Measles begins after a 10 to 12 day incubation period characterized by high fever, cough, runny nose, and red watery eyes. There's also the appearance of Koplik spots, which are small white dots found in the mouth, and a red maculopapular rash, which spreads from the face to your torso and then out to the limbs. And it's usually measles is usually self-limited, so it will go away on its own. But if it's left unmanaged or someone has a compromised immune system, it can progress into more serious complications. But only about 1 to 6% of measles cases develop into pneumonia, which is the most common cause of measles-related death. Measles also has a rare chance to develop subacute sclerosing panencephalitis. It's a progressive degenerative brain disease that usually manifests 7 to 10 years after the initial measles infection and is inevitably fatal. It is super rare, though, making up only 1 in every 100,000 measles. Pneumocystis pneumonia usually presents itself subacutely, which means it spreads fairly rapidly. Some common symptoms include a fever, chills, dry cough, dyspnea, which is a progressive shortness of breath, and chest discomfort. In some advanced cases, there's also cyanosis, which is the bluish discolorization of the lips or skin due to low oxygen, and this can develop and it indicates severe respiratory compromise. If left untreated, it's almost guaranteed that pneumocystis pneumonia will result in respiratory failure and death. The infection causes an interstitial pneumonia that impairs oxygen exchange. Without the appropriate treatments, PCP is nearly always fatal. If untreated, patients will develop worsening hypoxemia low blood oxygen. This condition leads to shortness of breath even while at rest. PCP can be life-threatening even with treatment, but if left untreated, it will continue to spread in the lungs and is often deadly within weeks. There is no antiviral cure for measles, so treatment is primarily supportive. This includes hydration, antipyretics or fever reducers, and nutritional support. In severe cases or high-risk exposures, passive immunotherapy with measles immune globulin can be given soon after exposure to prevent or attenuate disease. While antibiotics do not directly affect the measles virus, they can treat any secondary bacterial infections brought about by measles, such as ear infections or bacterial pneumonia. Measles is preventable, however, through a live attenuated vaccine known as the measles, mumps, and rubella, or MMR vaccine. This vaccine has been in effect since 1963 and is given in two doses, the first at 12 to 15 months and the second at 4 to 16 years. The two doses of MMR induce immunity in nearly all recipients, virtually eliminating susceptibility to the measles virus. Another method of containing the measles virus is herd immunity. This is when a majority of people in a population are immune through vaccination and they act as a barrier protecting those who are not immune. For pneumocystis pneumonia, antimicrobial therapy is required. The first treatment is trimethoprim sulfamethoxazole, or TMP-SMX. This is a high-dose antibiotic regimen that is given over the course of 21 days. This Therapy can be given orally or intravenously and is highly effective at clearing the pneumocystis infections. If patients cannot take TMP SMX, which is often due to a sulfa allergy or other side effects, there are many other treatments such as atovaquone, pentamidine, or combinations such as clindamycin, primaquine, or dapsone trimethoprim. In moderate to severe cases of PCP, adjunctive corticosteroids are often administered early in the course to reduce lung inflammation and improve chances of success for later treatments. For patients already in respiratory failure, supportive care such as oxygen supplements or ventilation may be required to keep the patients alive long enough for treatment to work.
The epidemiology for measles is before the creation of vaccinations. Measles was ubiquitous. Basically, every child eventually contracted measles, and the disease caused enormous morbidity and death. The disease sickened 3 million to 4 million people and led to about 500 deaths and 48,000 hospitalizations every year in the US globally. Measles caused millions of deaths every year before immunization through vaccination was implemented. After the vaccine was introduced in the 1960s, the incidence in the US dropped by over 95%. By 2000, endemic measles transmission was declared eliminated in the US. This means that any case since then have been linked to international importation rather than domestic spread. In more recent years, the US has been a resurgence in outbreaks where there were 667 confirmed cases in 2014 and 1,282 cases in 2019, the highest in 25 years. This is due to pockets of low vaccination in some areas. Overall, measles in the US is far less prevalent than in other portions of the world, such as regions of lower immunization, like parts of Africa and Asia. For the epidemiology of pneumocystis pneumonia, it was practically unheard of in people with normal immune systems until the late 20th century. Prior to the AIDS epidemic, PCP was a rare curiosity that was mostly seen in malnourished infants or patients with profound immune suppression. It is hard to find an exact number of how many people were diagnosed with PCP pre HIV, but the CDC estimates less than 100 confirmed cases in the early 1980s. However, PCP incidence skyrocketed among young adults with AIDS. Approximately 3 out of 4 people with advanced HIV or AIDS developed PCP in the absence of prophylaxis. Pneumocystis pneumonia became one of the defining opportunistic infections of AIDS. After effective HIV treatments and prophylactic antibiotics became available in the 1990s, the incidence of PCP in HIV positive populations declined dramatically. There are no systems in the US that keep track of PCP right now, but studies have found that about 10,590 people were hospitalized because of it in 2017. In resource rich countries, PCP has become less common due to better preventative measures, whereas in regions lacking widespread HIV treatment, such as parts of Africa and Asia, PCP remains a significant cause of illness in AIDS patients. Who or where was affected by measles and PCP? Um, Measles remains prevalent in many developing regions, such as parts of sub Saharan Africa and Asia, where immunization is lower. This is most likely due to there being a high population of malnourished and immunocompromised individuals. This, coupled with the lack of medical care, makes the spread of measles much easier. The main groups that are at risk for measles are children that are less than 5 years old, pregnant women, and immunocompromised individuals. This is either due to lack of vaccination or lack of a powerful immune system to fend off measles. Adults can contract measles too, and those are over 20 years old tend to have more severe illnesses than teenagers or school age children. For pneumocystis pneumonia, it is a ubiquitous organism, meaning that many species are exposed to it in early childhood. But PCP disease is almost exclusively seen in immunosuppressed populations. The highest risk groups include people with HIV or AIDS, specifically with CD4 counts that are less than 200. Roughly 20 to 40% of PCP cases occur in patients with HIV. Others at risk are organ transplant recipients and those with prolonged corticosteroid or chemotherapy regimens, such as patients with hemo- hematologic cancers or autoimmune diseases who are on immunosuppressive drugs. Geographically, PCP is more prevalent in developing countries where HIV is more prevalent, and there is limited access to effective anti trovial therapy.
One popular measles outbreak is the Disneyland outbreak of 2014-2015. This is when an international traveler visited the park and transmitted measles to numerous visitors. The virus then spread among communities of unvaccinated individuals, and by the end of this outbreak, there were approximately 131 confirmed cases that were traced back to Disneyland exposure in California. And additional cases spread to 6 other US states as well as Canada and Mexico. Public health officials detected the outbreak when multiple people presented with measles shortly after the new year. Fortunately, no one was killed in this outbreak, but many people were hospitalized. Pneumocystis pneumonia generally does not cause outbreaks in healthy populations, but small clusters have been documented in specific scenarios. One important cluster of PCP occurred in Los Angeles in 1981 when 5 previously healthy gay men were diagnosed with pneumocystis pneumonia. This unusual cluster was reported by the CDC and was the first public indication of the emerging HIV and AIDS epidemic. This means that before this, many patients had unexplained immune deficiency. Now, despite treating the patients with trimethoprim sulfamethoxazole, 2 of the 5 men died from respiratory failure. The cases were eventually linked to a new virus, HIV, which caused AIDS. In this case series, taught clinicians that PCP could occur as an outbreak among individuals with common risk factors, which was in this case immune suppression due to HIV.
Some interesting facts about measles is besides the rash, measles has a profound effect on immunity. The virus causes immune amnesia, which it destroys the host's pre-existing immune memory cells, effectively erasing protection against previously encountered pathogens. After measles infection, survivors are left as vulnerable to other infections as a newborn.
An interesting fact about Pneumocystis jirovecii is that its closest genetic relative is not another human pathogen, but Taphrina deformans, and this is a fungus that causes peach leaf curl on fruit trees. And Pneumocystis jirovecii was historically misidentified as Pneumocystis carinii, and this was due to people believing that it was a protozoan, and it actually was a fungus.
Question 1. Why does measles appear to be more on the rise in the US? Question 2. What is one country that you might find more cases of PCP in than America?